Hey, welcome everybody. So I'm Todd McCarty. I'm excited you're here. We do have some really interesting ideas and new innovative therapies for weight loss that I'm going to tell you about. So here's what we're going to talk about tonight. The background, why is obesity such a problem? Be honest with you, it's really simple. It's a difficult issue, but the explanation is really simple. We're going to go through some of the medical options, the surgical options. I'm going to tell you about a gastric sleeve. The gastric sleeve is now the most commonly performed weight loss operation in the United States. I've been doing it for about 10 years, but it's essentially replaced the band and it's starting to replace a gastric bypass. I'm going to tell you a little bit about NOTES surgery. NOTES is an acronym, means Natural Orifice Transendoscopic Surgery. That's a really fancy way of saying we go down your mouth to do surgery inside the abdominal cavity without having to make cuts on the stomach. I'm going to tell you about a mini sleeve. This is a technique that I pioneered starting in 2011. We're up to about 200 patients now. It uses NOTES as an approach to do a sleeve to really shorten recovery and to decrease the risk of the operation. I'm going to tell you about a new intragastric balloon. That's the Bariatrics balloon. We'll talk just a little bit about revision surgery so you know, and then what you want to do if you want to move forward from here. So obesity trends. This is a map that's been around for a long time and gets updated by our Centers of Disease Control about every year or two. And it doesn't take much to see from the early 90s to 2010, and now it's even worse, that the incidence, the prevalence of obesity in every state is going up. And it's not simply a problem that is limited to the United States. It's a global issue now. Virtually every developed country is having an issue with obesity. So why is that? It's simple. Fat is an energy reserve for your body. Okay? It's a virtual savings account. In case you don't have access to food, your body starts to metabolize the fat. It protects you if you don't have access to food. And any extra energy intake that you take now, if you take it in the form of carbohydrates, if you eat fat with your diet, your body is going to take that fat and store it away in the fat cells so they can use it at a later date. Now, that may have been really helpful a long time ago when we didn't have access to food, but in today's society and in developed countries with food so readily available, we take in extra energy in the form of fat or carbohydrates. We just increase the fat stores on our body. Not to say there's not a genetic component, because it clearly is, but that's simplicity about why it's happening. So what is the effect of dieting? When I first started doing this, by the way, I came out of just a little background here. I finished my general surgery residency at Baylor. I went to Southern California, did 3 years of surgical oncology fellowship, big operations like removing the esophagus and the stomach and the liver and pancreas and things like that. I came back on staff here at Baylor in 1998, and I did my first weight loss operation. I didn't want to. Okay, it was an internist of mine who was a very dear friend who really forced me to look at it. And when he first told me, I said, no, I'm not going to do it because I saw it as a resident. I don't believe that it's helpful in the long run, and the operations then weren't. But I told him I'll keep an open mind. Well, it just happened to be when gastric bypass was coming around, and so I read about that. I said, okay, I admit the patient. We did a gastric bypass. We worked through the aftercare together. And the thing is, it was impossible not to recognize the benefit that she got. She was a teacher. She was on disability. She had arthritic knees and hips. She couldn't get up and around. She had diabetes. She had hypertension. Ann Morton's her name, and I don't mind telling you because she's still a patient of my practice 16 years later. It was impossible not to recognize that. And by the way, when you're treating cancer patients, and I don't know if any of you have had it or your family have had it, when you treat cancer patients as a surgeon, the goal is to cure somebody. You don't go to a surgeon unless you're going to get cured. But the reality is many times we don't. And when we don't cure it and it comes back, there's not a lot we can do. And it took a very heavy emotional toll on me trying to deal with that. Weight loss surgery was exactly the opposite. So over the years, I did them both. I helped Baylor start their weight loss surgery program back in the early 2000s, and I've gravitated towards just doing weight loss surgery. One, because I have a passion for it. It works. When I first started doing it in 1998, there were 2 surgeons in this city who did it. And I took a lot of flack for it. Flack from the medical staff, flack from nurses, flack from other referral physicians, and the bias against obesity. But we worked through that to a point today where there are 57 surgeons in this area. And I don't have to tell you that. You drive down the freeway, there are billboards everywhere. There are 57 surgeons now who do weight loss surgery. But in that time, The advice that was previously given of, hey, look, you just got to eat less and exercise more, hasn't worked. And it doesn't work for two simple reasons. Your appetite goes up and your metabolism goes down. More calories coming in and the body slows the metabolism down to fight it. I like to make an analogy to a savings account, okay? If you had a savings account and every day you were spending more money than you took in, the first thing you do is stop spending so much money. If you have to take out of that savings account every day, you stop spending so much money, and that's what the body does. It recognizes it. When it has to burn fat as a source of fuel, it's a completely different pathway. The other thing is it increases appetite. This is regulated through a hormone that's made in the stomach called ghrelin. This was first identified in 2004, and now it's an integral part of what I think is the best part of a sleeve gastrectomy, is because it's the first operation that treats the physiology of obesity. And decreased metabolism, it's just reducing energy spent on processes that aren't vital to survival. So here's the deal with ghrelin. This is really important. Ghrelin is made in the stomach. Ghrelin rises through the day, stimulates our appetite. We eat till we're full, so it's made in the stomach, goes up to the brain. There are other components to our appetite. It's certainly not as simple as a single molecule, okay, but this is the main player, and this is why it's known as the hunger hormone. So it's made in the stomach. It peaks 3 times a day, and that corresponds to breakfast, lunch, and dinner. And the way it works is it starts low and it starts going up, and we start to get hungry. If you don't eat, or if you've never had access to food, you got hungry, you just didn't have time to eat, there wasn't anything around, and the hunger pains kind of went away. Because ghrelin will drop back down unless it's stimulated. But if we get hungry and we eat and food falls into the stomach, it stimulates it more. And it stimulates it until we're full. And then the stomach stops secreting that hormone. It's because the cells, and you can see them staying here, live at the very bottom of crypts in the stomach. And they have receptors inside that sense tension and pressure. They're called baroreceptors. And as that stomach starts to expand out to hold the food, when that wall starts to stretch, that's what they sense. And so up it goes until we're full, and it drops down. It takes a few hours for it to drop because that's how long it takes our stomach to empty, and the whole process repeats itself. So if you're trying to diet and not eat as much, and you never stretch your stomach out, you know what's going to happen to your ghrelin levels? They go up. And that's why we end up hungry. And that hunger is a very primitive drive, and it's hard to overcome long-term. What's the chance of attaining a healthy body weight? And this is really what's driving the interest and the volume of weight loss surgery in the United States. And this is from the American Journal of Public Health, just published 2015. If you're an obese man, obese meaning a body mass index, what I'm going to go through, over 35, you've got a 1 in 210 chance of attaining a normal body weight. Slightly higher for women, but if you get into the severely obese category, those are long odds to be able to get your weight down and keep it off. And most of the patients that I see, to be honest with you, it's not that they haven't lost weight. Some of them lost 100 pounds or hundreds of pounds in their lifetime. They're just putting it back on, right? And so what this speaks to is long-term health. Every study that's been published for severely obese patients who state a non-surgical approach is beneficial have been limited to 3 or 6 months follow-up. If you go back and find those patients at 2 years, they've all put their weight on, plus some. So when you get to this point, we can talk about medications. I'm happy to treat with some medications, but if you're being realistic with yourself, it's not going to work in the long run. So body mass index, we talked about. Body mass index standardizes a person's height relative to weight. If you're 250 pounds, it's different if you're 5 foot versus 6'5", right? And so basically a body mass index under 25 is healthy. 75% of the United States doesn't fall into that. They're over that. 25 to 30 is overweight. 30 to 35 is in the obese category. And once you get over 35, you get into different categories of severe obesity. This is where surgery really plays a role. I will point out that things are changing in here, and I'm going to point out why medications don't work and maybe what some of the options are. Okay, so the treatment guidelines for medications are a body mass index over 27.5 if you have medical problems. You got diabetes, you have heart disease, you have hypertension. That's the FDA guidelines for prescribing weight loss medications. Or a body mass index over 30 with or without. For surgery, you get into a body mass index greater than 35, okay, with coexisting medical problems. Or a body mass index over 40 with or without. The question again becomes what to do when your body mass index is 30. I can tell you I have patients who come into the office and who have been through multiple diets and tried multiple rounds of medication, have been treated by physicians, and their body mass index is 34. And guess what? Insurance doesn't cover it. But we all know what's going to happen. And it's frustrating for them. They're like, well, what do I need to do? Go out and gain some more weight and then come back in a year? Well, unfortunately, that's what the insurance companies follow, but I can tell you surgery really is starting to play a role in here, and it's beneficial.